I'd like to thank Professor Carol Faulkner, Associate Dean for Academic Affairs, for organizing this event. And I'd like to also acknowledge with respect the Onondaga Nation, the indigenous people on whose ancestral land we now stand. It's a pleasure for me to introduce our moderator, Grant Rear. Grant is the director of the Campbell Public Affairs Institute and a professor in the Department of Political Science. Many of you also know Grant as the creator, host, and producer of the Campbell Conversations on WRVO Public Media, an award-winning weekly regional NPR public affairs show that features in-depth interviews with regional and national writers, politicians, activists, public officials, and business professionals. Thank you so much for being here today. Grant?
Thank you, Dave. I also want to thank Carol for putting the panel together and having the idea to do it. There's general agreement that in his 2 terms, President Obama's signature domestic policy achievement was the Affordable Care Act, the only policy change commonly known by his name, Obamacare. The law contains multiple provisions designed to increase health care coverage, contain overall costs, and improve the quality of health care. Many analyses of the bill's effects, including work, for example, by the Commonwealth Fund, have indicated that the act has had some significant successes in all 3 of those areas, including bending the overall cost curve despite the headlines about premiums and deductible increases. Passed in a period of intense political polarization and without Republican involvement or support, the law was also the most controversial domestic policy change enacted during the Obama years. It remained a central bone of contention in the presidential campaign of 2016, and changing it made the top 10 policy to-do list of a new Republican administration working with a Republican Congress. Defending the act immediately became a clarion call for the political progressives' resistance against Donald Trump. But Republicans have had their own problems in trying to change it. All of that is an obvious backdrop and a motivator for this panel today on thinking about healthcare and healthcare policy futures, but we also want to broaden our conversation today to things beyond the ACA and the handicapping of its future, but of course we'll be talking about that. We've got a great panel from the Maxwell School representing our different backgrounds, knowledge bases, and areas of expertise. So let me just briefly introduce them and then introduce how we plan to proceed. Tom Dennison here on your far left is a professor of public administration and international affairs and a senior research associate at the Center for Policy Research. He's also the director of Maxwell's certificate program in health services management and policy and the director of the Lerner Center for Public Health Promotion. In addition to his academic expertise, he has served as a chief executive officer of a hospital, the administrator of a nursing home, and the executive director of a network of ambulatory care centers. Perry Singleton, next to Tom, is a professor in the economics department who specializes in public, labor, and health economics. His research focuses on the effects of health on labor market outcomes, the economics of the family in relation to health, and social insurance programs. Cynthia Morrow is, and she is next to Perry, is also a professor of public administration and international affairs and holds the Lerner Chair at the Lerner Center. She's a medical doctor with a degree in public health. Dr. Morrow also holds appointments at the State University of New York Upstate Medical University, and she has served as the Commissioner of Health for the Onondaga County Health Department. And last but not least, Jennifer Karas Montez is a professor in the sociology department and the Gerald B. Kramer Faculty Scholar of Aging Studies. Her work focuses on inequalities and life expectancy across social class and across individual states in the U.S., particularly in terms of gender, and the effects of social and economic policies on these factors. And as Dave mentioned, I'm Grant Reher, director of the Campbell Public Affairs Institute. So here's how we'll try to attack this really sprawling area of healthcare and its future. First, Tom Dennison has offered to provide us with a brief backgrounder on some basic features of the current situation in the country in terms of health and health policy, and maybe get into some of the politics of that, we'll see. And then we'll pivot from that to some questions that I'll throw out to the group that will tap on the different expertises of the individuals and of the group collectively for a group discussion. I'll interject from time to time. And then following that, what we'd like to do is have a conversation of this very select, we happy few of the whole. And to that end, we have some microphones that we'd like you to speak into when you're participating in that. It's not so that other people in the room here can hear you, it's so that you're part of the archive that we're making of this and that will be available to folks through our website. And if you can, direct your question to a specific panelist, or I may route it there, but if not, we can handle that otherwise. So, Tom, do you want to get us started? Thanks. Okay, great.
Thank you, Grant. So I will do my best to be as apolitical as possible as I wander through some of the issues around the Affordable Care Act. I will reserve the political part for our conversation. So it's really important in the beginning to point out why we have this great big interest in healthcare, and it basically boils down to cost. This slide shows us the increase in spending in the United States on a per capita basis from 1960 projected through 2023. And you can see that the costs have marched along very steadily, increasing, and we project that they will continue to do that. Healthcare spending, the lighter line above the purple line, is almost every year exceeded gross domestic product, and the top line is the percent of healthcare as a percent of gross domestic product, national health expenditures. So we've again seen increases on those measures. The United States is unique in its spending patterns. The United States spends about 40% more than you would expect it to spend based on its wealth. This graph shows us a regression analysis that looks at national health expenditures against gross domestic product per capita for most of the developed countries in the world, and you can see they cluster very, very nicely along that line. The economists in the room see an R-square of 0.71, which makes them very, very happy. The United States, the little red diamond up at the top, is inexplicably off the line, about 40% higher than one would expect. So, but one would expect that if you spend that much more, you have much better quality. This is a World Health Organization ranking of select healthcare systems, really the countries that we compare ourselves against: Australia, Canada, France, Germany, Netherlands, etc. And you can see that the United States ranks 11 out of 11. So we're the least well ranked among our peer countries. Now, we're very well ranked in terms of some of the quality issues, but access is where we really take a beating, because from a financial point of view, we have more barriers to access than most any other country. This gives us a perspective on the type of insurance that people have. This is another thing that sets the United States apart from other developed countries that largely have a single-payer system or one government option. We have a variety of different payers. We have private health insurance, public health insurance. The US is unique in that we spend about 50-50 public versus private. Public is actually increasing a tad, but when you look at other developed countries, they're 70, 80, 90%, up to 100% public dollars. We rely very heavily on the private sector, which sets us apart and causes some of our problems in the way we finance. You can see on the part of the slide closest to me, we have the uninsured, and then we have those people with some form of coverage. And you can see that as we go from 2014 to 15, 2013 to 15, we had a decrease in the number of people who are uninsured, really all attributed to the Affordable Care Act, and an increase in the people who have health insurance, again, attributed to the Affordable Care Act. One of the slides on this where it shows us employment-based insurance, you can see that there was no change, virtually negligible change, and that's one of the things that people complained about the Affordable Care Act, that employers would wholesale walk away from providing health insurance coverage. Indeed, that was not the case. We did, however, have an increase in the number of people covered under governmental programs, largely Medicaid, because the Affordable Care Act did increase coverage under the Medicaid program. The uninsured is now at the lowest point that it has been since we began to measure uninsurance. We're down to about 10.3% of the population, again, largely the effect of the Affordable Care Act. Since the 2010 law was passed, people were asked whether or not the share of people who were insured decreased, increased, or stayed about the same. You can see from this slide that about 31% of the people polled, and this is a poll done by the Kaiser Family Foundation, it's really quite reputable, about 31% of the population said, well, the number of people who are uninsured after the Affordable Care Act went up, when indeed it actually did not. And I think this is a hallmark of the Affordable Care Act. People don't understand what's in it. We've done a singularly poor job about communicating what the Affordable Care Act actually includes, and that has a lot to do with its popularity or lack of popularity. Speaking of which, this is a survey that's again been done by Kaiser starting in April of 2010 right through April of 2017, asking people whether they are in favor of or against the Affordable Care Act. The blue line is favorable, the orange line is unfavorable. It's gone back and forth ever since the Affordable Care Act was passed, and we're actually right now in April of 2017 at 46% in favor and 46% against the Affordable Care Act. So I wouldn't really call that a groundswell of much of anything, except when you ask people whether they are in favor of the Affordable Care Act by political persuasion. Then indeed you see a difference of opinion. There are other ways that this data has been cut by age, by sex, by income, and it virtually the same. There's really no pattern except by political party, which is an interesting phenomenon in the United States. This is another important data point to have tucked away. When we look at the concentration of spending in healthcare in the United States, we find that the top 5% of users spent 50% of the bill in any given year. And healthcare is not one of those experiences that is consistent over your lifetime. It's a very random experience. You never know from one year to the next whether you're going to be in the top 5% of users or the bottom 5% of users. So we have a huge disparity between the people who use healthcare in a given year and who don't use healthcare in a given year. And this is important when we think about the kind of payment mechanisms or insurance mechanisms we might want to see in our healthcare system. The majority of the US consumers said that this piece of legislation that was proposed by the Republicans was a good thing that it was not passed. Although the interesting part there is if you break that 64% in half of them said, well, we don't really want the law repealed, and the other half said, we do want the law repealed, but we didn't like the piece of legislation. So that's, again, a difficult thing to interpret. Very quickly, a couple of provisions comparing the Affordable Care Act to the piece of legislation that was proposed by the House. The individual mandate was included in Obamacare. This has been the piece that's been most contentious. The Republican proposal repealed the individual mandate. So it basically said you do not have to buy insurance if you don't want to buy insurance. It also repealed the employer mandate, which is an interesting piece in itself. Many people thought when the law was passed that this employer mandate was going to be a huge burden. It is a burden from a reporting perspective, but that it would have enormous impact on employment and on employment-based coverage. And as an actual matter, it really had very little effect on employers. Employers offer insurance to make sure that they can recruit employees. The allegation that the Affordable Care Act caused employers to increase copayments and deductibles also is really just an artifact of the reality that healthcare costs have continued to increase. Employers have pre-Affordable Care Act and post-Affordable Care Act changed their offerings to reduce their spending. So the Affordable Care Act really had very little effect on employer-based insurance. The Obamacare had subsidies for out-of-pocket expenses, pretty significant subsidies. Those were repealed by the Republican plan, and now we have tax credits. I won't get into the fine points of the difference in terms of how those supports are provided, just simply to show you that under the Republican plan, the tax credits go up with age, not adjusted to the local cost of care, which the Affordable Care Act does, not adjusted for any other variable. But premiums under the Republican plan can go up to the tune of 5 times for older people. So your premium will go up twice as much, and your subsidy will go up twice as much, and your premium may go up 5 times as much. So when you translate that into what would actually happen across the country, compared to Obamacare, compared to the Republican plan, the people who are most advantaged are people who are in high income groups and are younger. So the older, low-income people really get whacked with the Republican plan because of the structure of the subsidies that are in place. Obamacare versus Republican plan with respect to Medicaid. Obamacare, the Affordable Care Act, expanded Medicaid or offered the states the opportunity to expand Medicaid. The Republican plan rolls that back and basically grandfathers some people into Medicaid, but then as people roll off Medicaid, new people would not be eligible for a higher federal subsidy. So it effectively rolls back the Medicaid eligibility in many states and is a disincentive for states to expand their Medicaid programs. So a number of states would be disadvantaged. The blue states were the ones that actually did increase Medicaid coverage under the Affordable Care Act. The center of the country did not largely increase the Medicaid coverage. So when you look at political party again and ask whether or not it's a good thing for the Republican plan to have been failed by political party, the Democrats thought it was on one side of the equation, the Republicans on the other. Great.
Thank you, Tom. That was a lot of material very quickly and in a very clarifying way. There's a journalist who I have a lot of respect for said to me once, all journalism involves simplification, but there's simplification that clarifies and simplification that distorts, and you have managed to hit the former with your presentation of the slides. Thanks so much for that. As someone who's come off 2 years of back-to-back complicated back surgeries, I'm looking forward to 2017 with the year that I don't make the top 5%. So fingers crossed on that. I'm sorry about that for the last 2 years. I have questions that get to some of the things that your slides raise, but before I start into that, let me just ask the other 3 panelists, are there things that you saw there from Tom's presentation that leap out at you or that you're burning to comment on? Jennifer, do you have anything that you'd want to add to that you think is central to setting that base understanding, and then we'll go from there. I have a question or two for you later about inequalities, but go ahead now.
Right, and I think that what I would ultimately like to do today is broaden the discussion and put the Affordable Care Act in context of all of the other things and levers that we have to improve health in the U.S. Okay. I don't know if this is the right time to do that, or we should focus more on...
Well, if you want to throw out a couple, signposts or things that you want to have us thinking about now, I think that it's a fine time. Go ahead.
Okay, so one of the bigger contextual questions that I have is, what are we trying to accomplish with the Affordable Care Act and with medical care more generally? So are we, for example, is the objective here to make sure that we all have medical care coverage, that we all have access to care? And if that's the case, then this focus on ACA and resolving the controversy and getting a plan that we can all agree on seems like a really good use of everyone's time in Washington. But if the objective here is, on the other hand, to improve the nation's health, then I'm a little less convinced that focusing so much time and controversy and capital on the discussion around ACA is going to get us there, given that medical care is one piece of overall input into health in one piece of what determines our health individually and as a nation.
Thanks, great. Cynthia, did you want to?
We talked a little bit before this. I think that one of the things that always leaps out to me in the discussions of the ACA is, and reform, subsequent Republican reform plans or replacement plans, is the lack of discussion of the other things that the ACA addresses. So, for example, and this is just a tiny example, so few people understand that part of the ACA was to require workplaces to allow women to have access to a room that was suitable for breastfeeding and have time for breastfeeding. There are many, many other examples of what the Affordable Care Act did to try to address things outside of health insurance, but we don't seem to talk about those. And the huge elephant in the room for that is the Prevention and Public Health Fund. 12% of Centers for Disease Control funding is now funded by that fund, which under the Ryan plan would just disappear. And we're not having the conversation of what does that mean if we fundamentally unfund 12% of public health funding. So to me, I think this is a great example of what the Affordable Care Act is trying to do, but we're not talking about it to the same level.
Perry?
Yeah, I think the slides were great at laying out the background of healthcare in the United States and the ACA bill. One thing that I would like to stress that Tom kind of alluded to is the concentration of healthcare expenses among the population. So the Tom slide had mentioned that 50% of the most costly, biggest spenders of healthcare account for 97% of all expenditures, which is a lot. But you could imagine raising it up to the top, say 20% or 15% of spenders, and it still accounts for a large share of expenditures in the United States, which is to say, a small fraction of people who have pre-existing conditions or chronic conditions account for a large share of healthcare expenditures. And I think policy like the ACA and some of the Republican proposals are really focusing on these big, kind of more expensive people who spend a lot of money. And I think that really is the ballgame when it comes to health insurance reform.
So I want to get into some of those things in a few minutes, but I want to back up, and I do want to ask a couple questions about the current politics surrounding the efforts to repeal and replace the ACA. And I know from conversations that we've had individually, and some of you don't consider yourselves experts in this field, but the good news is that the last 5 months have made non-experts of us all. So I don't think Paul Ryan knows the answer to this question, so don't let this hold you back. But although we want to get into this broader discussion, let me at least start with a question or two about Obamacare and its replacement. Let me ask the group to explain, and it gets to some degree, I think, at the pie charts, a couple of the charts, Tom, that you put up about how people see this and also the misconceptions about things perhaps too. But let me at least start with asking the group to explain why do they think the effort to repeal and replace Obamacare, which the president may or may not have moved on from since the first failed effort in the House of Representatives, why this broke down politically, and how likely is it that you see some significant reworking of it to happen in this 2-year term of Congress that we've got? I don't know who wants to jump in on that, but I would be very curious to see what the group thinks about those two questions. Why did this fail when it looked like the day after the election, the assumption was that there would be a big change? And then what is your sense of the prognosis of how much of it is going to stay in place during the next 2 years? Tom, do you have a sense about that?
Well, no one ever really knew how complicated healthcare actually is.
Well, there's another problem, right?
So, I think that's part of it. I don't think that the Republican side of the House or the opponents of the Affordable Care Act took enough time to truly understand what the guts of the Affordable Care Act actually are. And I don't think that the general public has a deep enough understanding of what the Affordable Care Act actually represents. And when they began to pick at the Affordable Care Act as it stands, I think politically, people began to realize there are things in here that my constituents very much value and were afraid of pulling those back. So I think they got caught in being unprepared to deal with the realities of what the change would have to be.
You're nodding your head, Jennifer. That's your take too?
Well, I agree with that 100%. Another thing that's really interesting about health and healthcare that I think plays into the contentious nature of the discussion is that unlike a lot of other topics, the levers that are being moved in our legislators' offices, healthcare, and I just read a study on this recently, healthcare consistently is one of those where there are really disparate views on who's responsible for health. And there's, a contingent that thinks it's an individual's responsibility, right? Government is responsible for ensuring people have jobs, that, the potholes are filled in the road, infrastructure kind of issues. But when it comes to health, well, that's the individual's responsibility, don't smoke, don't do this, and whatever. And, there's another group that thinks, more broadly, that there are these structural conditions that allow us to, live a healthy life, and sometimes, or, put constraints on us in others. And those two viewpoints often kind of map onto political party. I mean, they vary within party, but they map on as well. And so I think, again, just like a lot of other issues, health is one where there's pretty strong conflicting views on who's responsible for it, government or the individual.
Other thoughts on that? Yeah.
Well, I think a really clear example of that was the discussion about the essential covered benefits, and the Freedom Caucus feeling very strongly about not covering them, and even moderate Republicans feeling that they did need to cover them. And an example from the public health world is prevention screening. And so in my world, we should have zero barriers for people to get colorectal cancer screening. It's evidence-based. We know what the return on investment is, clear outcomes. But some people feel like that should, if you can't afford a colonoscopy and you don't feel like that's your priority, why should I have to pay for it as the government? And I think that that's just a really clear example of what Jennifer was talking about, just this really clear ideologic divide about whose responsibility it is.
The one thing that I think kind of gets lost in the debate and kind of confounds it and makes it a little bit confusing on what the responsibility is, whether it's on the individual or the government, is when we confound these concepts of insurance and versus redistribution, right? And so as an economist, when I talk about insurance, I lecture about insurance, which is separate from a lecture about redistribution. And sometimes, right, if we're thinking about businesses running an insurance program and they have to presumably be profitable in order to stay in business, that's very different than saying redistribution versus people who have pre-existing conditions and having to essentially redistribute money from the healthy who can work to those who are less healthy and can't work. And so I think that, if we're thinking purely about market solutions, which is what a lot of Republicans think about, that works only to the extent that this is a market for insurance. And a lot of times the things that we have to deal with as a society isn't really insurance. When someone has a pre-existing condition, you're no longer insuring that condition, you're just redistributing money towards that condition, because at that point the risk is gone, right? They already have the condition, and so there's nothing there really to insure, it's just redistribution. So I think in this kind of wrapped up in this ideological debate about what the best strategy or policy is for our society, I think we need to disentangle what we mean between insurance and redistribution.
Well, I wanted to also tap in directly to some of the concerns and points that Jennifer, Cynthia, you raised at the beginning after Tom did his initial presentation. But let me ask this other question about making changes and revisions to Obamacare. It's something that on one level I understand and I get, and at another level I'm a little bit mystified by. oftentimes, to listen to the political discussions since the presidential election, it sounds as though what is at stake in this discussion of changing Obamacare is a fundamental retrenchment of the public commitment to health care that would take us back to a much earlier point in our history, our fundamental commitment to care for the elderly, for instance. So I want to explore that for a minute. I'll put it in a very blunt-edged and perhaps arguably even crude way. If Obamacare, in terms of this fundamental public commitment, if Obamacare took us beyond the situation that existed in 2008, and now we're considering, or our Congress is considering, a set of revisions to that law, why won't we end up with something that's between the status quo ante of 2008 and the current situation? Why is this the end of the world as we know it? Which is what it sounds like sometimes when I hear it discussed. Go ahead.
Yeah, so my interpretation of the ACA is that there are a bunch of provisions and counter provisions that are kind of interacting with one another within the same bill. So you might have an expansion to Medicaid, but expansion to Medicaid might therefore distort private insurance pools that you would see in the private market, and therefore there are other provisions to address that, like subsidies for insurance premiums within the exchanges. And so for me, it seemed that the ACA is kind of, at the very end, the final product after months and months of deliberation. It was this fine kind of balance and counterbalances of different provisions that just together worked. And the issue that I think with the Republican proposals is that you're basically, it's kind of like a Jenga game, right? You're like, if you take one block out of the stack, it all kind of falls apart. It doesn't work. The ACA, you can't just simply take pieces away and then expect you to be somewhere in the middle. It could in fact be worse than where we were 2008. And I think the reason why the ACA bill looks like this is because, we are kind of the ACA bill was kind of state dependent in the sense that, if we could hypothetically clear the deck and start completely from scratch, I think a lot of people, including a lot of Democrats, would have preferred, say, something like a single payer. But in the world that we were at in 2008, in the bill that we had to write, it was not the perfect bill, but it was still a bill that progressed us forward. And thinking about kind of parsing out pieces of it, I think it's almost impossible because so many pieces are interconnected with the bill that it's hard to think about each one in a vacuum.
So just to push you a little bit further on this, and maybe the answer here is obvious, but so one might hear that and say, okay, we don't want to play that game, so let's just take the whole stack and get rid of it. And then we're back to 2008. So not true, or address that.
I think one thing that's interesting legislatively is different states' responses to both Republicans having the control of the House and the Senate and the presidency, as well as ACA being kind of a target for reform. States have responded in many different ways to try to create a firewall between the federal government and what it can do and what can states do. So one great example is in New York State. The state legislature is currently considering a bill called the New York Health Act, which would establish a single-payer system in New York State. And so for me, when you say clear the table, I don't mean clear the table like let's go back to 2008. I mean like let's clear the table and really establish a single-payer system in New York State, which therefore could be used as a model, similar to Massachusetts health reform was a model for ACA. New York Health Act could be a model for a national single-payer plan, and that's an avenue I think that might be fruitful.
So Tom, let me ask you a question about that before you jump in. I know you want to jump in before, but give me, if you could, a percentage chance possibility that New York will have a single-payer system.
Very low.
Okay.
Very low.
Okay.
But implicit in your initial question was that we actually have a policy on a national scale, and we do not.
Okay.
So if you look at the Medicaid program across the country, that really is the bellwether for how willing our country is as a country to actually have some sort of coherent health coverage. So in New York State, We have probably we do have the most generous Medicaid program in the entire country. And we also pay a lot of taxes in New York. Those of us who live in New York know that well. Go to Missouri. Missouri did not expand the Medicaid program under the Affordable Care Act. Missouri offers no Medicaid benefit, none, for an adult with no children, ineligible. Missouri's benefits level, even for those people who have Medicaid, is very, very thin. So this opposition to the Affordable Care Act is as much, in my view, about the right of a state to decide what the minimal benefits are as opposed to what kind of national policy we should have. We don't have a national policy.
Either of the two, you want to jump in on this topic? Cynthia, Jennifer? No? It's okay.
Well, I think that the other thing that makes it difficult to go back to 2008 are just cultural changes. So, once you've expanded to children up to 26 being covered, it's really hard to take that away. And from the healthcare perspective, I think we have had a cultural shift in healthcare about looking at other determinants of health, about really seriously thinking about volume-based to value-based care. And I think going back to 2008, it's changed. The playing field has changed. And I just don't think at this point there's any possibility of us undoing things like the expectations of accountable care organizations and patient-centered care, medical homes. Those are concepts that have now become embedded in at least the physician population, and I think in the consumer population as well. So I just think that we're in a different place.
Well, let me jump off of that, and having brusquely swept off the Perry's suggestion of New York single payer off the table, I want to put it back on again in a way at the national level, and it builds off of a slide, Tom, that you put up, and I wanted to ask about this, so I was glad that you showed all of us the numbers on this. It's about this idea, thinking more broadly, of whether as a country, despite the fact that we are such a clear outlier, that we are on some kind of slow, uneven march toward something that's going to make us look like the other countries. Maybe we'll be spending more, but still, eventually we'll get to something that will look more like a single payer system or something like these other countries. And let me put it this way. One thing that I think both extremely progressive and extremely conservative activists in this area do seem to agree on is that these incremental expansions in the public part of the healthcare system can be seen as steps being taken toward this end. I mean, I have heard people in both of those camps use that language, one with hope and one with horror. But they agree on that. And then to think about it in terms of those proportions, Tom, that you put up of public and private spending. The United States has traveled a fair distance in the last 4 or 5 decades on where that dial is. And if I understand correctly from what I read, Obamacare did push that dial a little further toward the public side. So where are we, do you think? I mean, is that a right metaphor to be thinking of the big long term for the United States on this issue and the national policy regarding it? Or is that just fundamentally mistaken to think it's this sort of long, uneven march, kind of like a civil rights struggle in the United States, where it was not steady, but we're still on it. But there is a curve that you can see.
I don't know if I would describe it as a curve. We have made progress since 1965, which is when Medicare and Medicaid were originally enacted. Medicaid was not ever seen as anything big then. It was just this small program that would take care of a few poor people. Medicare was a national position to say the elderly and the disabled should have some safety net of care, and that we've maintained. Now, it's controversial now in terms of its stability and its long-term financing, and we're beginning to see ways proposed to chip back at Medicare because of its cost and because of the nature of its financing. So I don't see any groundswell to improve Medicare. Medicare, if we really had it as a safety net for the elderly, would have a lot more benefits in it than it currently does. Medicaid was kind of an accident. that Medicaid particularly became the long-term care insurance for the middle class, and that Medicaid covers 50% of every baby, of every delivery in New York State is paid for by Medicaid. So Medicaid has really become an enormous benefit in many ways. But it's really been a function of the failure of the insurance market. Nobody wanted to cover the elderly because they're a disaster, and nobody wants to cover the poor because they're a disaster. So the government has to step in and provide that coverage. Now we've got the middle of the population. We are the only country that relies this heavily on employer-based insurance in the entire world. Switzerland has a few similarities, but that's about it. And we're very reluctant to let that go. Employers would love to see it go. But I don't see us on any sort of even trajectory, or I don't see any sort of grand plan.
I share your skepticism. Yeah, and I mean, so sure, there have been a lot of states that have bought onto the Medicaid expansion, but even so, I mean, it's still a means-tested program. There's still a lot of stigma associated with Medicaid. Like, I don't see that as a trajectory moving us to a place where I think a lot of us would want to go. Another reason for my skepticism is maybe detached from healthcare and what's been happening there. But if it still surprises me that we are now 44th in the world in terms of life expectancy. And since 2008, we've seen life expectancy decline among certain fractions of the population that are getting bigger and bigger. So you would think that there would just be this groundswell, like people being really mad, like, I want health and I want health care. And this is really frightening. We are at the bottom of OECD countries in our health and our life expectancy. And even that doesn't get enough people motivated to want to make a significant wholesale change to our healthcare system. So if that doesn't do it, then what will it take? I don't know.
Well, go ahead, Tom.
We haven't defined the problem broadly enough, which is really your area more than mine. Housing, nutrition, the built environment, violence, those variables cause more poor health than the absence of medical care itself. So if we don't begin to do something about housing, and really it boils down to employment and ability to have access some sort of wealth so that you can live a lifestyle that is healthy, that's what's going to improve the health of the population, not having more cardiac surgery or not having more access to pharmaceuticals. Medical care is, for some people, a necessary but not sufficient condition to produce good health. But poor housing, no education, inability to have a job, not having nutrition, that's a guarantee that you're not going to have good health.
Well, let me jump in on that and ask each of you to make your own list then for precisely this question. And it's the topic that Cynthia and Jennifer, you both introduced at the beginning, is to have this broader view and say, what do each of you regard then as the biggest challenges to our health, and if you want, to our health care that neither Obamacare nor the proposed replacements are sufficiently addressing, and which we as citizens and future policymakers need to be thinking about. I mean, is it housing? Is it obesity? What are they for each of you? Tom, you gave us a quick list. Perry, do you have a ready list of your own?
I think I don't really have a particular list, but I think that there's increasing evidence that that income inequality is associated with, so greater levels of income inequality is associated with, say, lower life expectancy, worse health outcomes. And so kind of taking it more broadly than just employment, thinking about how income inequality leads to psychosocial stress, in the sense that, there's some evidence and theories to suggest that when income inequality increases, it not just hurts people that are at the bottom, but it in fact hurts people that are at the very, very top, because there's a sense, right, that you may be top 1% today, but living in a society where there is no safety net or there is no bottom, you could be the bottom 1% tomorrow. That alone leads to levels of stress, leads to that stress therefore leads to other health conditions like higher rates of cancer, cholesterol, hypertension. And so thinking about kind of broader social policies, not just health insurance, but social safety nets and redistributive policies like higher taxes on the wealthy, capital taxes, income taxes, to redistribute. I think that those things play into the health disparities that we saw in the graph of OECD countries.
Absolutely. I think that education, so if you look at from a population base, which is a greater predictor of poor health outcome, income inequality is, I think, an enormous, it should be an enormous priority, but disparities in education are better predictors of poor health outcome than disparities in income. And of course, they're so closely related that I think in my ideal world, universal pre-K, a lot more home visitation for women at risk for poor pregnancy outcomes, and just women living in poverty, or women who, even if they're not living in poverty, who are poorly or don't have high educational achievement. Again, those go hand in hand in our country. That's where we have the biggest bang long term for the buck in terms of health outcomes.
I agree.
We're all on the same page.
So let me try to tie it all together. So I've been doing some work with the team over the last couple of years, and we've been trying to understand why there's such disparities in health and life expectancy between U.S. states. Okay. And so we've been trying to disentangle how much of that difference is due to the characteristics of people that live in states, whether it's race, ethnicity, education, or whether it's something to do with the state's policies, okay? And a broad range of policies, things that have to do with unemployment and taxes and you name it. And so what we find is that it's coming from both ends, right? So education in terms of individual characteristics is the most important. That it doesn't matter what state you live in, if you have at least 1 year of college, your health outcomes are pretty consistent. But if you don't have at least 1 year of college, where you live matters a lot. Because without your own resources, you're much more, the resources around you are much more salient to your life, right? So that is, just kind of highlights the key role that our own human capital brings to this. But in terms of the states, so if you looked at, like I said, so many different just overall characteristics and policies, and what turns out to be the most critical time and time again was, we call it social cohesion. So it's the amount of income inequality in a state, the amount of social capital. Do you know your neighbors? Do you participate in community events? The amount of crime and unemployment. We lump all those together, we call them social cohesion. So those two pieces seem to explain a very large fraction of why health and longevity differs so much between states. Much more so than did Medicare, Medicaid, and looking at state-to-state differences. So that would be on my wish list.
So let me
education, income inequality, social capital, unemployment, and crime.
social capital.
Yeah.
So let me jump from the state level to the local level and return to Cynthia here and propose a thought experiment for you. So let's say that we do consolidate our government here in Onondaga County, and there is one single executive, and it's you. What would you do if you wanted to increase the health of Onondaga County? What would be your most important initiatives? If you are it's been called by the critics, we're going to establish a czar in Onondaga County. So you're the czar. What do we do?
So I'm very biased. I think we need to start preconception, and so in my ideal world, every woman would have a child in a neighborhood where there is social cohesion. How do we get there? It's really difficult, but what we do know, so get back to my past, what we do know is that the hardest to reach individuals in Onondaga County in terms of poor outcomes, poor birth outcomes, poor maternal outcomes, are also they have the worst outcomes, and they're the hardest to reach in terms of our penetration of our social services, because we are very rich in terms of services. So in my ideal world, I think that we would create a much better, I'm thinking of some of the things that we do in the near west side in terms of community engagement. If we could build trust in services in the communities that have the worst outcomes, so that they could access the resources that are there, I think that we could really move the needle. And again, I think that we have to start before children are born. We know that if families, not just women, read to their children in the first year of life, those children's long-term outcomes are much better. So if we can get to families, not just women, and build that trust so that they can utilize the existing resources, I think we could really change the trajectory. That sounds really pie in the sky, but.
Well, you're the czar. So
I'm the czar.
it can be pie in the sky. So let's see what folks want to ask or add to the discussion that we've heard. It's covered a lot of different ground here. Anybody want to jump in? Yes, go ahead, sir. And there's a microphone that's coming to you.
I have a specific question and a comment, too. Tom, you mentioned that you didn't think that New York State would implement a single-payer system, and you were very quick to say that, so I'd like you to elaborate on that. Just tell us why it's not possible. Is it because people like Flanagan or DeFrancisco are in the pockets of the insurance industry or other issues? But that's one thing. And the other is a comment. Nobody brought this up, but I think one reason why we don't have a healthy public debate on this whole matter of a workable healthcare system is that we have a corporate media that's not giving us enough information on this topic in a way that the public can understand it. There are interest groups like I mentioned, the insurance companies, the pharmaceuticals, and others perhaps that they have some domination. And we know a lot of people depend on Fox News for their information. So I think a lot of people are not getting information that we really need to debate this in a healthy way. So the question for you, Tom.
I think the special interests are still too strong to really accomplish a single payer in New York State. The insurance industry is enormous and has enormous amount of power, and they are very much not in favor of a single payer system. The provider system really is of two minds. You have a group of providers, and there's a growing group of physicians who want to see a single payer because they have seen the disruption in care that the multiple payers create. More than that, the increase in expense that they incur in their private offices simply to accommodate the volume of paperwork and the approvals and that nonsense. When I first started managing physician practices in the 1970s, it was about 50% overhead, 50% physician income. We're now at about 75% overhead and 25% physician income because of the administrative noise associated with managing a practice. The hospital system, they're of two minds. They're burdened by the paperwork and the administrative cost associated with managing multiple payers. On the other hand, supply side power is an important thing. So the fewer payers, the more payers they have, the more negotiating power you've got. You have no negotiating power with Medicare. You have no negotiating power with Medicaid. You do with the private insurers. And we've created a system where the private insurers subsidize Medicare and Medicaid on a wholesale basis. The hospital industry, the nursing home industry are nervous about that. So I don't think that the economic incentives are aligned at this point.
I'll jump in as a honorary panelist for a minute to also put some other answers to your question. And Tom or others, correct me if I'm wrong, I believe the last time I looked at a figure on this, something like a third, or at least a very large chunk of the entire income tax revenues from New York State come from Wall Street, taxes on Wall Street incomes. So if you're thinking in those terms as a legislator, you're playing around with fire when you start thinking about something that big. The other thing I would say is just to underscore how hard it is. It goes back to the social cohesion, I think, Jennifer, you were talking about, but take the state of Vermont. It's got social cohesion and trust out the wazoo. They have taken 2 big whacks at this in the last 25 years and come up short both times. So if Vermont can't do it, and think about how homogeneous that population is in comparison with New York. There's another complication when it comes to the politics of it. If Vermont can't do it, it's hard to imagine that a state like New York could do it.
My understanding is that Vermont did not pass single payer because they don't have the same tax revenue or base that Vermont does. In a state that has,
You mean that New York does, you mean?
that New York State does. New York State, from a study that was done on the New York Health Act, in order to implement single payer in the state, the budget would require a 91 billion, I think, per year shortfall. And so in that act, there is a proposal for additional payroll taxes and income taxes to fill in that gap. But when we think about, I think that there's a general perception that single payer is one of these programs that is very expensive and infeasible and politically impossible. But when we look fiscally, it's actually not that difficult. And if you look at the New York State Senate, there are currently 30 New York State senators that are sponsoring the bill, including members of the conservative Democratic, Independent Democratic Caucus. So there is some support. Do I think that it's going to actually pass, at least this iteration? I'm somewhat doubtful, but I'm still hopeful that keeping the discussion open about single payer and some of the advantages of single payer is what we should be doing. It's our kind of responsibility to at least consider that going forward.
And one of the problems I remember from the first time they were thinking about this, thinking about trust, is they trusted each other, but they didn't trust New Yorkers. So that one of the things that we're worried about is we do this and we're going to get these people coming in from New York that are going to want to be part of this plan. And so then you've got the interstate. It gets back to the interstate inequalities that too you were talking about. It gets back to the problem of having 50 states with shared boundaries, at least with one exception, which is, interestingly enough, the state where something has been done about this. When you're surrounded by an ocean, it helps. So, you know, it plays into that too. Who else wants to jump in? Go ahead, sir.
I have an ideological question, because it seems like with the disinformation on ACA and everything else, that the underlying thing is that healthcare policy, Ryan care, Trump care, must fail, because if ACA and single payer succeed, then all of a sudden we're this socialistic country. I mean, it's not an accident that Paul Ryan is an Ayn Rand guy, and that the former Fed chairman, what's his name, was an Ayn Rand sort of guy, everyone for themselves. So I don't think, number one, our media interests that are owned by huge corporate media are willing to ask the ideological questions about why this healthcare thing must fail, because it basically, in the Reagan years, government can't do anything. Government is the enemy. We're still fighting that battle. But I want, you know, Newhouse School and other journalism schools to step up and ask the ideological questions about why the Koch brothers and other people, I mean, the healthcare thing is the tip of the iceberg. And if this fails, then government can do nothing. So, I don't know, it's a big question, but I want ACA to succeed, and I want single payer to succeed. But I think we can't get there because this 35, 40-year thing of government is not working and can't work.
So you're suggesting and asking whether then this battle and this debate when it comes to healthcare is really something symbolic of much more, something that's much more general.
To me it is.
And
it's an ideological...
absent the merits of the particular issue is what it sounds like.
It's an ideological thing that questions the value of each person, and if each person is really worth insuring. I mean, it's incredible to me to think that conservatives, that Republicans, think that if we don't have insurance, the best, most financially best thing we can do is to send people to an emergency room. It's not cost effective.
So let me see if the panelists want to engage this proposal about how this is what actually is going on. Go ahead.
I'll just say, I teach public economics. I'm a public economist, and when you think about markets and the way markets are discussed or explained to students, it's the idea that free markets are the best we can get. Right, the society reaches the pinnacle of welfare when markets are completely undisturbed. The issue, though, is that there are many assumptions to get to that conclusion. And as you start to pick away a lot of those conclusions individually, the whole markets just completely fall apart. And so that's the case with insurance. A lot of people look at insurance markets, private companies providing insurance, as a market just like we would have for apples or widgets and guns and butter. But it's not, right? There are a lot of things that are unique about the health insurance market that just make them impossible to allow free markets to provide that type of insurance. And so for me, the ideological debate is whether or not you believe that free markets are the best we can get. If that's the case, then government should not be involved. But the reality is that that's not the case. And there is a strong role. I think, going back to the discussion about Medicaid and Medicare being expanded, and is that the end game? For me, that is the end game, because I can rest assured that markets will continue to fail, and the market will continually get smaller and smaller until everyone is on some type of public system. That's the way the system, that's the way the market and insurance works, and for me, that's the end game.
Yes, go ahead, get the microphone here. Thank you.
I wanted to hear a little bit about cost. So Tom had that great scatter plot where we're way up here. And we know that cost is distributed incredibly unequally across populations based on their access. Something that we've thought about a lot in the health econ and policy class that I've been teaching this semester is what is it about Americans that we're unwilling to recognize the need to ration anything? So in a single payer system, you have to queue. You have to queue up. That's the price. We're not willing to queue, we say. You need to have a formulary. You need to have covered things and things that are not covered. Well, our Medicare doesn't allow us to use cost effectiveness analysis as a measure of coverage. We have to cover everything. What would it look like, or what do you think is the barrier to us sort of finally kind of opening our eyes to the fact that this stuff just costs money, and if we don't want to spend all the money, all of our money, whether it's through the government or through our own pockets, what do we need to do to help ourselves catch on to what every other country has figured out about limiting costs somehow?
Well, every other country that's addressed this question has come to some sort of national position, some sort of national policy. We're a confederation, and state by state, we have very different perspectives on what is reasonable for people to access and what is not reasonable for people to access. Arizona didn't have nursing home coverage under its Medicaid program until the Reagan administration allowed them to have a Medicaid program without nursing home coverage. The District of Columbia does not cover physical therapy under its Medicaid program, period. It's not a covered service. They don't see that it's of value. So until we have some sort of national position on what coverage, what services ought to be available, we're never going to get to making decisions. We continue to acquiesce to the private interest groups. The piece of legislation was passed that created Medicare Part D, Medicare drug coverage. Everybody said, isn't this a great thing? We now have drug coverage under Medicare Part D. There's a kicker in that law that says that the federal government is prohibited from using its bulk purchasing power under Medicare Part D to negotiate for drug prices. It's against the law. What kind of country would pass a law like that? If you're interested in actually saving money. the Affordable Care Act has money for clinical effectiveness review. So we're actually spending money assessing whether or not things work. And then if we find out, no, they don't work, Medicare is prohibited from using the results of those studies to make a coverage determination or not. What kind of a country would pass a law like that? So until we stop acquiescing to the private interests, we're destined to keep these Band-Aids going, and we're not going to actually wrestle the cost question down. The Affordable Care Act does little to none, other than the things that Cynthia referred to, like the accountable care organizations, and we have a piece of legislation that was just passed called MACRA that actually is intended to bring physician Medicare billings down. We have pieces and parts of savings, but largely the Affordable Care Act was simply expand coverage. Some people would argue, well, it was intended that way to make the cost so unbearable that we actually would begin to deal with the cost question.
We did have some rationing. It just took a world war for us to do it. I've got the coupons in my house from my grandparents during World War II. That we did ration some. I don't know if that's not the answer. Probably you want though.
I think there's also a mindset here that plays into it, right? I mean, I think this in some way ties back to this idea of American exceptionalism, and also some misinformation about our healthcare system. I mean, if you turn on the media, you're not going to hear these sobering stories, right? You're going to hear that we have the best healthcare in the world, and we're making this discovery, and the FDA has just approved this and that. And I think you get this sense that things are going so great, why would I wait, right? I mean, I live here, why would I wait? And so I think that feeds into this a little bit, this exceptionalism. And I mean, we have some data on this as well. So if we, actually compile up the statistics on our rates, age-specific rates of death, age-specific rates of cardiovascular disease, of hypertension, we are near bottom. But if you ask people in the US and all those other comparison countries, how good do you feel? We report the very best, which makes no sense, right? But I think it goes back to this idea that we are exceptional and we should not have to wait. We're in great health, and the data completely are to the contrary.
And I think when we do ration every day, but we do it based on socioeconomic status. And so I think that we just don't have the honest dialogue that we are absolutely rationing healthcare utilization, and we're doing it by SES. So I think it gets back to, we're exceptional for those of us who can afford to be exceptional, right?
Yeah, and I would say, I've done a lot of research looking at the impacts of health shocks, disability on the ability to earn money, on the ability to be employed and to have health insurance. And I think Cynthia's right in the sense that it seems kind of very backwards mentality that when someone is in their worst state of health and they need health care the most is when insurers turn around and charge the most money and the highest prices. And that's how we ration currently under the system. I think the ideological question that we have to ask ourselves is, do we think that the rationing process should be decided by a board of executives at an insurance company, or do we think it should be decided through the legislative process, through voters saying, is this something we as a society are willing to pay for to make sure that those that are least fortunate among us have the health care and the income that they need?
Just to go back to the ideological question, Paul Ryan got up with some whiteboards and pointed at a slide and said, look, can you imagine having healthy people pay for sick people? That's, I thought, the definition of insurance, but that's an ideological position.
So, yes, go ahead, Carol. I have Carol, and I have one quick question at the end.
So I just want to say thank you first, because I've learned so much in this panel that I don't get from trying to avoid the news on a daily basis. So, but I wanted to raise the issue of the sort of anti-maternal criticism of health insurance that seemed to come out in the debate over the American Health Care Act, and this sort of hostility to pregnancy or taking care of children that sort of shapes the debate over health care in America. And this includes sort of general women's health care, as well as taking care of pregnancy and early childhood education, and why this is such an obstacle in American debates over health care and health generally.
It's just not fair to expect men to pay for maternity coverage. We don't use it.
Healthy people pay for sick people.
Yeah.
Men pay for women.
They're
Outrageous.
not part of
Young
it.
pay for old. Let me pose this as the final question. In terms of health and healthcare policy, given your sense of this as citizens and analysts, give me something to feel good about. Each of you. Give me something to leave this room feeling good about. Not everything has been so positive in the last.
Well, as much as we criticize the U.S. healthcare system, we do have pockets of excellence. We really do. I mean, there are pieces and parts of our healthcare system that are excellent, if you can access it. And I think the defenders of the U.S. healthcare system will say, well, everyone can go to an emergency room. This is true. Emergency rooms are required to undertake care. This is true. Once they begin care, they cannot abandon a patient until somebody else has agreed to take them on. This is also true. Once you get in the hospital, it's essentially payer neutral. It's payer, the nurses, the physicians, the hospital, your payment status is invisible to them. You get the very same care that you do as if whether you have the best insurance or whether you have no insurance. And when we work with international students and I tell them this, they look at me like, you know, that's not true. It is true. I've worked in the healthcare delivery system for a very long time, and that is actually the case. So we do have those attributes that are very positive. We pay for it. You know, it's moving the deck chairs around on the Titanic to think otherwise, because it's in your insurance premium. It's in the cost of Medicare. It's in the cost of Medicaid to take care of people. And it's regrettable to see people reach a point where they are in extremis before they actually can access that care. Then once you're discharged, now I'm not being positive.
Yeah, I was going to say, the question was what to feel good about. So you had me for a while, but
yeah.
Perry.
Yeah, I mean, I think that one thing that I find super kind of reassuring is that that states, I think, seem to be legislatively stepping up to the plate to address some of the issues or some of the policy reforms that could potentially happen at the federal level. So I'm optimistic. New York Health Act, at least the discussion is out there. We're still debating it. I think we may not have had that discussion with such urgency had it not been for the AHCA. Something else that had happened recently was Maryland's state legislature had passed a bill that would fill any expenditures. So if the federal government were to pull money from, say, Planned Parenthood, the state of Maryland would fill in that gap. And so to see that, like, kind of all is not lost if things that states are kind of addressing can be a firewall for things that happen at the federal level, I find helpful and reassuring.
Great.
And from my lens, I think that one of the things that the public health world has gotten a little bit better about is evaluation, which, you know, Tom teases me that public health and evaluation, it's all funny math, but the reality is that we are putting more effort into good public health evaluation, and so the studies are starting to show that communities that invest in things that improve social cohesion, that improve, well, it's more population health initiatives, but things that improve community-based prevention actually show decreased mortality in those communities. So, for example, a 10% increase in community prevention-based strategies, which if you're starting from no funding, 10% isn't a lot of money, results in a 1 to 7% decrease in preventable mortality. So I think that we are growing the evidence that supports that if we address the root determinants of health, we may benefit financially in the long run, and I think that's what people want to see.
Last word, Jennifer, last word.
So one of the glimmers of hope here is that, and this ties on to what Perry was saying, is that we do have states in the US that seem to be doing things right, okay? And that's in terms of healthcare and many other kind of social and economic policies. So there is a model out there for how these policies can be put together in a way that, you know, leaves those states with health and life expectancy indicators that do look like a lot of countries, you know, in North and Western Europe. So we have a model for how it can be done, and at fairly low cost. You know, things that states can do that invest in their population's health, but don't really cost a lot, like offering the state's own EITC and, you know, raising the sales tax on a pack of cigarettes. We find time and time again are big health boosters to a state. So that's my hope, is that if we can shine the light on those states that say, look, this can be done, you know, right here in the US of A, you know, maybe we can be hopeful.
Well, thanks to all four of you. Really, we covered a lot of ground, and we covered a lot of different perspectives in covering that ground. So I just want to thank the four of you for doing such a splendid job of having this discussion today. Thanks.